Page 396 has got regulation of glomerular filtration rate. What it's really just showing us is, really overall, it's showing us kind of how we regulate blood pressure in the sense of mainly the mechanism for helping us keep our blood pressure up. So our kidneys have all that blood flow through them, so they're great for reading blood pressure. So this, summarizing this again, I kind of just highlighted the kind of step one in the end, is that step one is basically saying in the glomulus or around the glomulus, the arteries coming in and out, we have these juxtaglomerular cells, as soon as the board wakes up, that read drops in blood pressure. That tells them to release an enzyme that's called, or an inactive enzyme called renin. It goes through a bunch of steps. I wouldn't stress the steps so much. It's one of those things where it's a little bit hard to make you know all this for a test that has other stuff, but I will say you don't want to kind of forget the RAA system because, again, I mentioned, like, for example, ACE inhibitors is a drug that specifically controls blood pressure by messing with this. So if you kind of forgot about the steps, like this conversion here in the lungs, that's what ACE inhibitors are targeting to help control blood pressure. So stopping this process, basically, or slowing this process down. And again, this is like micro adjustments, little tiny adjustments, very small movements of like 1 millimeter of mercury lower than like our normal range. They might kick on, and this is over every, pretty much every nephron has got juxtaglomerular cells. So big key is know the name juxtaglomerular cells. What do? They release renin in response to drops in blood pressure. And the ultimate goal of that renin is to do an enzyme cascade to eventually target the adrenal glands to release aldosterone. And what does aldosterone do? It tells to reabsorb salt. It tells the tubules to reabsorb salt, which salt sucks. So water is going to follow. If I increase how much water I don't let go and pee through the kidneys, it's going to overall, like I talked about with a water hose or whatever, it's going to increase the amount of fluid that's in my blood vessels, therefore slightly increasing blood pressure. So again, this could happen just small drops in blood pressure. This could happen if I was bleeding to death. I mean, it's going to kind of happen either way, but it's all about reading little tiny adjustments in that tiny arteriole coming into the glomulars. So again, all the other steps of renin going to the liver, angiotensin 1, converted to angiotensin 2, targeting the adrenals, blah, 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 blah. That's a lot of steps. So what I kind of circle is where I'd hint to is like renin is part of this RAA system. The eventual goal, get aldosterone released so we raise blood pressure. And it's kind of that negative feedback loop. If these juxtaglomerular cells are reading blood pressure is A-OK, they're going to stop releasing that, then this process stops. And so it's just to help us micro-adjust our blood pressure based on that. Does that make sense? We did get there, right? I'm like, okay. I know everybody's asleep today. It's okay. So again, I always think videos are nice just to put it in perspective, but that's kind of what's happening. You know, renin, or as he called it, renin. I don't know where he, I don't know where he got renin from, but whatever. Page 397 talks about tubular reabsorption and secretion. If you kind of remember, the three things our kidneys are doing is excretion, right? Filter, create a filtrate, push all the stuff out, make a filtrate, makes this. And then after that, the tube's job, that's that renal corpuscle, just that glomerulus with the Bowman's capsule, that first section of nephron, all about the filtration part. Make the filtrate, push stuff out. The rest of the tubes is all about reabsorbing, meaning it's going to go back into the bloodstream, or secretion, letting it stay in the tubes all the way until it becomes urine. And then again, once we kind of get out of the nephrons, we get out of the collecting duct, and whatever liquid and minerals that's left that ends up in those calyxes is in that area, those tubes inside the kidney, it's going to be urine. There's no going back after that. This is I always just leave this in. There's not any test questions from page 397, okay? But it's just kind of nice to look at and see what's happening. This is the more advanced, like what is going on in the nephron as a whole. So basically, just based on those tubes, like size and the way they're positioned, like the loop has a purpose and that sort of stuff, they're going to, again, reabsorb or hold on to certain stuff. So they're just telling us that typically, right, we kind of push out everything into filtrate. So glucose does end up first in the renal tubules. Electrolytes we want to keep, fluid in general, that sort of stuff. But there's also stuff we want to get rid of. And so eventually, as they get into the tubules, it's just saying that some of it's going to go back to the bloodstream. The tubules are going to reabsorb stuff that's in the tissue around them still and what's in here. And then that trend continues. They go through the loop, and a lot of times our blood vessels are here. They're going to reabsorb water, reabsorb sodium, that sort of stuff, depending on what we need. Same thing. At the end, it's still kind of a heavy electrolyte. The distal convoluted tubules like focus on heavy electrolytes. And then you can see that they tell us too, at the end, the collecting duct is all about water reabsorption. It's all about reabsorbing whatever's water's left and concentrating that, turning it into urine. Because if you were to say describe urine, it's concentrated, and you can kind of see this, right? If you're like dehydrated and you haven't been in the bathroom all day, the first time you go pee, it's probably pretty yellow. I don't know, might stink, I guess, if you had asparagus, but whatever. We know that urine smell or that. I know that very well. My 4-year-old peed the bed last night. I don't know why. Here we are. That was 11:30 last night. So, that was one of those two where they wake up standing over you. Ha! What? I give her credit, though. She changed her clothes. It was in fresh, dry clothes, so I'll give her that, I guess. But I'm like, what the heck happened, child? That's called stubbornness to the nth degree. My kids are like that. They don't. It's like if you tell them you should go pee before you go to bed, they're like, they told me to do something. No. How about no? Because they told me to do something. They'll hold it, go to bed, and okay. Anyway, sidebar: stubbornness of my children. But again, urine that's really concentrated has like more of a smell to it. It's more acidic. It's more yellow. For example, if you were really hydrated, sometimes you go to pee often, but that pee is like clear, less yellow, more watery. It doesn't smell as much. It's less concentrated. More concentrated urine means it's got more solutes in it, more particles in it compared to the amount of water, basically. And so the collecting duct, remember, collects from multiple nephrons. Multiple nephrons are going to come in here. And its job is kind of the last hurrah to say, depending on the water balance of the tissue around it, again, kind of the idea of diffusion and particles wanting to equal out. Same thing with osmosis. Osmosis means that we want to kind of equal out our particles. So water is going to naturally flow to try and even it out. And so if the tissue around the kidneys is well hydrated, then not that much water is going to be reabsorbed. But if the tissue around in these nephrons in the kidneys is kind of have less water molecules, we're in the desert and we're dehydrated, well, we're going to probably reabsorb a lot of that water, and it may be so much that we barely make any urine and we don't need to pee. There's a show, well, some of you may have heard of Top Gear, but they did a show called Grand Tour with those same British guys. And there's an episode where they're in the Sahara for like days filming, and they usually do like these long road trips, random stuff. And they are all joking, they're older, but they're all joking about how they hadn't peed in 2 days. And they were being serious, and that's probably very likely if they're in the desert, they're sweating all day, and they're not drinking enough water. That's probably going to be happening. So, because your body's trying to keep it all, because everything else around it's dehydrated. So again, there's not like I need you to memorize exactly what chemicals go out in the proximal convoluted tubule, that's a little bit too far in the weeds, but I think it's just worth talking about, like this is kind of how it works. Again, compared to whatever the tissue around the nephron is, diffusion is the guiding principle along with osmosis of just like where's the stuff going to go? Where's the particles? Where's the water going to go? It wants to kind of even it out. So what is the glomerulus? How would I describe it? This is some options for you. If this, again, this is from the book. I don't always like all their wording. But if you had to pick one thing to describe it, this is all you got. Remember, on a test, you only have what's given to you, right? If you start assuming things or trying to make up things outside of what the question asks and what the answers are, you're going to kind of trip yourself up. So you can only work what the question gives you. So out of what the question's given me, what's kind of best, closest to describing a glomerulus? Anybody? Nobody wants to take a shot? Okay. Which one, B or D? What'd you say? D as in dog? Mm-mm. 2 would be the closest. Again, I don't necessarily like saying capillaries. The reason they're calling it a capillary is because the glomerulus is somewhere that stuff is pushed out of and then make filtrate. But it's not a capillary to me. As we're talking, we have an artery, right, where it meets a vein. That's a capillary. And so I think it sets you up for confusion, but that's what they're talking about. I would call it a network of tiny arterioles that looks like spaghetti. There's your layman definition. That's what the glomerulus is. All these branches of these tiny arterioles that's designed to be tiny and high pressure to push out and become filtrate whatever's in there and just return the big stuff. Fluid of the blood, blood cells, that sort of stuff. Everything else kind of gets pushed out. Remember that 99% every day of everything that runs through our nephrons, especially the glomerulus, is going to end up is going to become filtrate, but 99% of that gets reabsorbed. And so only 1 to 2% of that ends up being urine a day. So that's about 1 to 2 liters a day is your normal urine amount. And so if you are looking at page 397 there, it does have a body of work section at the bottom that tells you a different number for the average amount of urine a day. Ignore that. I would stick with the easy numbers because it's using numbers 720 to 240 or 2,400 milliliters a day. That's way too weird and specific. That's on page 397. So ignore that body of work. I would stick with kind of that idea of that my glomerular filtration rate, I should be getting like 180 liters a day made into filtrate, but I'm going to reabsorb most of that, and so whatever's left is going to be urine, and that's about 1 to 2 liters. So 1 to 2 liters of urine output a day is a pretty good range for most people, okay? And then the fast fact down there talks about glucose, which we already talked about. What should never be found in urine? At least 2 things that we should really never find in urine. There you go. Yeah, protein and sugars. We shouldn't find those in there because our body wants to use those. So that glucose might get pushed and made into filtrate, but it definitely should be something reabsorbed. So like I gave you the example that sometimes it might not be reabsorbed if there's too much glucose in the tissue around it, meaning hyperglycemia, maybe diabetes, that sort of stuff is whenever you might find glucose in urine. It's not the only thing, but that is why. Woo, okay. Try not to lose my voice today. So page 398 has basically this chart that's on the slide. And that's a ding, 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 star, highlight, asterisk, that chart, that sort of thing. Because we do have to talk about hormones because there's some hormones that affect our kidney, and a great deal. And some of these you've already heard of, okay? You just got to pull them back out of your memory from endocrine. So I already mentioned aldosterone. Aldosterone is saying, I'm reabsorbing NaCl as sodium chloride. I'm reabsorbing salt. Okay, I'm reabsorbing salt, so therefore H2O is water. Water follows. I wouldn't stress about what they secrete, but it's up here so much. Some stuff is going to have an inverse relationship, right? Sometimes we're going to pull in one electrolyte. You'll see this, that some of our electrolytes have like an inverse relationship. We'll talk about this with electrolyte and fluid balance in the next unit to finish off this term. But a lot of our molecules, especially the electrolytes, have like a normal range here inside the blood or a normal range inside the cell. And our body's all about homeostasis. That was like one of the first big words we learned. So it's all about a balance, whatever it is. So sometimes our kidneys play a huge role in kind of keeping that balance for what we need. So we need sodium for like every muscle contraction, nervous system impulse we do, but we also need potassium to help with electrical impulses, especially in cardiac conduction. So like both of those we need. It's just balancing them out. So I wouldn't care too much about excretes, but just overall, what does aldosterone do? Reabsorb salt. That's going to reabsorb water. And does it tell you, yeah, and the book gives you, this chart doesn't give it to you, but the book gives you effects on blood volume and pressure. Which typically, if I increase my blood volume, means there's more water in the hose, I'm going to increase blood pressure. So aldosterone's ultimate end goal is what it's going to do is increase blood pressure and blood volume. I'll do BV for blood volume. B is in blood, V is in volume. And so I think that's why this chart's so good. It gives you some more information, but basically it's just telling you where this is made. Adrenal cortex makes, or not cortex, adrenal medulla, but it doesn't really matter. It's talking about what the levels rise, sorry. It's made, the aldosterone's made in the adrenal medulla of the adrenal gland, right? If you remember that. So a lot of these you've heard of, but this second one that's on that list you probably haven't heard of. It's actually a quick mention in your cardiac chapter, in chapter 15, but I glossed over it to kind of mention it here now. It's a very quick, there's like a little blurb in this book about it, so the book doesn't spend that much time on it. But atrial natriuretic peptide, or again, a lot of these have shorthand, so you don't have to say atrial natriuretic peptide every time you say it. ANP. What the heck does that do? This is actually a hormone that's produced by the atria of your heart. They secrete it based on blood flow and that sort of stuff. Like what's flowing through there, they can kind of get an idea of what's going on. And they release this hormone. And what it does is it actually inhibits. You know what inhibit means? What does inhibit mean? Stop it. Try to stop something. That's the simplest way, right? Inhibit means I'm trying to stop something. Like if I'm inhibiting you from drunk driving, I'm taking your keys. I'm inhibiting that, right? Okay? I'm trying to stop that. So it actually inhibits the two hormones that do the same thing. We're about to talk about ADH again, but aldosterone and ADH are very similar. So it actually inhibits these guys. So by stopping them, which both of those guys, if you look at that chart, are about raising blood pressure and blood volume, that means that it's going to get rid of sodium, which what follows? Water. So that's going to, I ran out of room here. Let me move this over. Decrease blood pressure, decrease blood volume, because I'm losing more in urine. So that one's a more rare one. A lot of times we're actually trying to kind of keep our blood pressure up a little bit. Sometimes our blood pressure gets too high. We have this guy that can kind of help knock it back down a peg. So that's the first time you've heard of ANP, probably, unless you read the whole chapter 15, and you may have seen it in there, but it is a small little, like, one sentence about it. The other two you've heard of before. We've heard of aldosterone. This one, anti-diuretic hormone, ADH. If you kind of remember, we've talked about diuretics a decent amount. We talked about this with endocrine. So anti-diuretic means, I'm trying to increase urine output. So anti that means I'm going to try and stop increasing urine output. So again, this is very similar to aldosterone. They're going to have the same goal. ADH and aldosterone have the same thing. They're going to raise blood pressure up. They're going to raise blood volume. They just do it a different way. Mechanism of action-wise, aldosterone is about reabsorbing salt. ADH specifically is something that targets the collecting ducts and tells them to reabsorb more water. So, hey, more water, please. So it just kind of skips the step of worrying about sodium and water following and just says, just reabsorb the water. So both of these guys can act at the same time and help us increase blood pressure, increase blood volume. The last one is a nice mention, but it's not a huge one when it comes to affecting our blood pressure or our blood volume, how much stuff we have in the blood vessels. But you've heard of this one before too. PTH, parathyroid hormone. The only hormone that parathyroid glands, the ones that are posterior on our thyroid, the only one that it makes, called PTH. And all it cares about doing is reabsorbing calcium, which we need calcium for what? What do we need calcium for? Bones? Come on, y'all. Muscle contractions, nervous system impulses, blood clotting. Huh? What'd you say? Oh, sorry. I was like, the list goes on and on. Calcium is kind of like that hidden one. There are a lot of people think of sodium, potassium, bananas, salt. Yes, those are good things. Those are kind of keys. But as far as you talk about your biggest electrolyte after that, calcium. Calcium kind of pops up as a key mineral for helping us do a lot of stuff. And so that's parathyroid's job, is try to keep calcium. How does it do that? It tells the kidneys, who are the guys that mainly make filtrate and do a huge amount. Again, the kidneys are the main guy that's doing the controlling of how much do we get rid of and how much do we keep, okay? Based on what the body around them needs. So PTH is going to help us increase calcium levels. That's what it's trying to do. It has no effect on blood pressure or blood volume. So that's why I said, it's not really a huge one in this chart, but it is something to remember. Because this chart is just talking about hormones that affect the renal tubules. These are hormones that specifically going to affect how those tubules reabsorb or don't, okay? And these are the big three for sure. These never go away, ever, for you. The rest of the time you learn stuff, you're going to hear the word hormone again. You're going to hear the word aldosterone, ADH, and you're going to hear A&P some too, because we have there's some meds that help affect A&P to kind of help control blood pressure too. So it comes up again. But that's a need to know chart. You need to know aldosterone, A&P, and ADH. And PTH, yes, but those are the big three because they affect their blood pressure, blood volume. So the life lesson down there talks about diuretics. Do I have that? No. Okay. But yeah, 398 down there talks about diuretics. I feel like I shouldn't have to say it again, but again, we've talked about it a bunch in here. So diuretics increase urine output, basically. Diuretics do it different ways. There's different types of diuretics. There's loop diuretics, and there's potassium sparing, and there's a couple other ones. But overall, the goal of a diuretic is that word they highlight, and that makes sense, is the term diurese. Diurese just means to passage of large amounts of urine. That's how the book defines it, which I think is just, I don't know why it's funny to me, but that's about as simple definition for diuresing as you can get. And they say that in the hospital. Like if someone's in fluid overload because they have congestive heart failure, they say we need to diurese them. They use it like a verb or whatever. But that's just saying we need to increase the amount of urine, because if we do that, we're likely going to get rid of this extra fluid they have that they don't need. So diuretics' goal is to increase the amount of fluid we lose in urine. So probably increasing water. They do that different ways, but that's the goal. Again, I mentioned there's other drugs that kind of promote that. Caffeine. Caffeine is a drug. I joke. I mean, I drink caffeine all the time, but it is a drug, by the way. So I would send you down a YouTube rabbit hole, but I don't want to get canceled, so I won't. But if you look, there's a guy that's about ticking everybody off, and he makes fun of everybody, including himself. But he makes a joke about how what's his name? Logan Paul that sells the Prime is selling drugs to kids. That's his joke. Because Prime has 200 milligrams of caffeine and it's promoted for kids. That's a lot of caffeine. A can of soda has like 44. I think a Coke has 44 grams of caffeine versus 200. Okay, anyway, so I drink energy drinks every once in a while, like once a month or something when I get the urge, but yeah. Caffeine's a drug too. It's going to cause diuresis. Like I said, alcohol has the effect of helping cause diuresis. There's a lot of stuff that can cause the nephrons to kind of open up their ways, but that's all diuretics mean. So, page 399 talks about composition of urine is the title of it. And so there's just a couple points to make there. The biggest thing is that most of urine is water, okay? Most of it is water, but a few percentage points of it's going to be those hard chemicals, uric acid, urea, and things that we want to get rid of. The key point I make here is, I think I mentioned this before, but the best way to understand anything about like a huge thing, again, if I walk into the ER, they're going to ask me some questions. They're going to do like 3 things probably. They're probably going to get labs, EKG, and some urine from me, pee in a cup. That's kind of the big 3. Because if I have labs, I see how your heart rhythm is, or they hook me up to a monitor. They may not do an EKG, but they may hook me up to a monitor. So if I need to know the heart rhythm, and I need to know labs and their urine, you can tell a lot by somebody. That's why the ER does those big 3, because you can learn a lot of information from that. So as far as a general information gatherer, you can learn a lot about what's going on with someone from a urinalysis. A urinalysis is just analyzing urine. It's just understanding it, okay? So an examination of the characteristics of urine. So they talk about some of the characteristics in that chart on page 399. I'm not going to stress you knowing about those specifically. You'll learn about that in first trimester. I think that's redundant. I don't want to overstep and get too much stuff for you to test on with me. But things that you can kind of think of are obvious. Like I mentioned before, color. Like pale yellow, usually good. Dark orange, bad. Probably really dehydrated. There are some medications out there that change urine color. I'm blanking on the one right now. I'm going to have to look it up again. I know it. If I saw the name, I'd know it. But there is a drug that can actually turn your urine green. It's not Monster Energy drinks. I forget that movie's reference. But yeah, there's something that turns your urine green. There's another one that turns it like kind of purplish red and freak people out. So there's stuff that can mess with that. And then obviously odor. If you ate asparagus and your urine's really concentrated, it's going to stink. If you're really hydrated, it's probably not going to smell. And they talk about things like specific gravity and pH. These are all stuff you'll learn. So I'm going to say these are not need to know for me for my test, but there's talking about knowing different stuff. Like specific gravity is one of those things that they look at a lot with urine. They look at specific gravity, GFR, and what they call creatinine clearance or creatinine. And that's another thing you'll learn in first, so I won't stress you out about that. But again, some of this stuff, specific gravity is all about like just showing us dehydration. The higher it is, the more it is. So again, GFR, that glomerular filtration rate is a great indicator of how well the kidney is actually functioning. Sometimes there could be something downstream that's causing issues from the kidneys, but typically that's, and again, big stuff I shouldn't find in kidneys, definitely, or in kidneys, I shouldn't find in the urine is glucose, blood, proteins is the big one. Albumin's a plasma protein. Bile pigments, because the bile pigment we know of is bilirubin, and that's supposed to get excreted in stool. So if I find that in my urine, I've got all kinds of questions. It's probably some kind of issue with the liver or gallbladder in that area, but but big ones is definitely protein and glucose. And then I'm just highlighting this term that's in the Body at Work page 399. And you notice the first line says most adults produce 1 to 2 liters of urine a day. So I'm a little bit ticked at the book because right a page ago they gave us a different range for normal urine output. I don't know why they're doing that. So stick with the 1 to 2 liters of urine. That's 1,000 to 2,000 milliliters is a normal amount a day. So it says that if we have urine output less than 400 milliliters a day, it's basically insufficient. It's saying that that's not enough to like clear everything out, basically. So to clear out waste products, because remember, if for some reason the flow through the glomeralis and that part of the nephron is sluggish, then the filtrate production will be sluggish, and then the reabsorption will be like slower, and it's more time. Sometimes we'll reabsorb more waste products that we were trying to get rid of if that flow is all kind of slowed down. So it just depends on what the problem is, but that is equaling not clearing waste products. And if I don't clear waste products, this is why for patients, a lot of our drugs, our medications get processed in our liver, but they get cleared out of our system through the kidneys. And so if I have problems with my kidneys and I take a pain pill, I might get more loopy and disoriented than I would if I was having normal kidney function. And this is why they have kidney dosing for medications. Medications are dosed based on if someone has kidney issues chronically, they might change medication dosing because of this kind of reason. Because some people that are in like stage 3, 4 kidney failure may not make urinary at all. That's called anuria, but you don't have to memorize that for now. But they may not make urine at all. So they can't clear anything without going to dialysis. So we really have to be careful about what we give them, how much we give them, that sort of stuff. But oliguria is the term we talk about for low urine output. And that's a nursing like red flag, okay, to like, we need to probably follow up on this and see what's going on, okay? And from my experience, even sometimes the confused older guy, confused older lady, they may not know their grandson's name anymore, but I can tell you typically they know if they peed in a day or not, okay? They might remember that. Not always, but all I'm saying there's been plenty of times where there was a man that was a little bit older. He wasn't senile, he didn't have dementia, but people didn't always take him seriously. And he had told a couple people it had been a while since he peed, and turns out he had a bladder obstruction. He hadn't peed in days, and luckily his bladder didn't rupture, because it could have. I straight cast that man, and I got nearly 2 liters of urine out at one time. The bladder's not really made to hold that. Actually, it was more than that. I forget. It was enough. I did a straight cath, and a straight cath, you really just have a tray. It filled that up, and I was looking for buckets, like, pinched it off in my hand and had to grab something else. I think I grabbed a bucket underneath the commode, the pull-out potty. I grabbed that bucket and just put it under. I was like, we'll just do that. I don't know. So, anyway, he said, I've been telling him I hadn't been peeing. I'm like, well, I guess I'm glad I'm here today. So, listen to your patients. For the love of God, listen to your patients, okay? Even if they're crazy, because they might be funny then, you know. Depends. I mean, if you don't urinate at all, and you have if you don't have kidney failure, like I said, there's some people that don't pee at all, or they're chronically oliguric because their kidneys are just so not functioning. But they may only, like dialysis patients that have end stage, they may pee once a week, if that, sometimes, and it won't be much difference to them. But if they don't have kidney problems normally, if that's not their baseline at this point, then, I mean, I don't know how long it would take to fill it. Depends on how much they're drinking and all that stuff, but I mean, a couple days, you're going to be really uncomfortable. 3 or 4 days, you're going to be like, the bladder would probably be full enough that it's about ready to rupture. And then, again, the bladder is sitting in the very low part of our abdominal cavity and our pelvis, basically, and so that ruptures. Again, anything that's in there is going to spill out into the abdominal cavity, which, bad news, infection, all kinds of stuff. So, I've never seen someone's bladder rupture. Like, well, obviously I didn't see it with my eyes, but I've never taken care of someone that's happened, but I've heard horror stories, so. So we can finish this real quick and then take a break. We'll do some activities when we come back. So really, again, that whole first part of that chapter was all about the kidneys themselves, really, and how we make urine. That's the big thing about the urinary system. Again, they can't call it just the kidney system because it's about all of it, but the rest of this is real straightforward. It's literally just after it leaves the kidneys, if you kind of remember. Let me go back to a kidney picture, like a sagittal cross-section. Nephrons, yeah, that guy. Whoops. This guy. Again, those nephrons are all hidden here, mostly up in the cortex with their loops down. So all the nephrons and the collecting ducts here, are going to collect, and then they're making urine all into these calyxes. But once that liquid that went through the collecting duct is in these calyxes here, it's urine. There's no going back. There's no really reabsorption. These calyxes and all this and this renal pelvis here, these are just tubes. There's just stuff flowing through them. So once the liquid's here, it's urine, and it's just on a path now. Gravity and smooth muscle are just guiding it on a path. It's got nowhere else to go. So the first place it's going to go after leaving the kidneys is the ureters. Some people say ureters, but I think it's missing an E for that to be the right way to say it, but I don't know. You do what you want. So it goes kidneys, then the urine's going to pass out of the kidneys into the ureter. And the ureter is just a long muscular tube with each kidney that flows down, so descending down. It's about 10 inches, depending on the person. And they have some smooth muscle in them, and they do a little bit of peristalsis. You remember peristalsis, kind of like a wave-like motion in our GI tract? They do peristalsis in the ureters too. Why do you think that would matter? Why don't we just drain all of our urine by gravity? Why do we need smooth muscle at all in the ureters? Well, control, but think about what you do for about a third of your life. What do you do for a third of your life? Sleep, which you should be laying down most of the time, unless you're Dracula, right? Actually, I think Dracula probably lays in a coffin too. So if I'm laying down, what are my ureters fighting now? Gravity, right? So it always helps to have a little bit of smooth muscle, doing some little movements, keep all that flow going, okay? So smooth muscle in there, and both ureters come from each kidney, and they all deposit into one thing. We've just got this muscular sac way deep in our pelvis, so it's way deep in the abdominal cavity, down in the abdominal pelvic area, way down there, called our bladder. And our bladder is just a muscular sac, and it's just a hold for urine. That's all it does. So you can see the ureters come in posterior to it. I don't have the best. Yeah, it doesn't really show it that bad. But yeah, you can see how far down it is. The bladder's way down there. Way low in the abdominal cavity and the pelvic cavity area here. But the ureters come in posterior, kind of behind it, and deposit into its back wall. That's the ureters coming in. They come in like this, behind our bladder. And they deposit urine in there, and all the bladder does is sit here and hang out until it fills up. It's filled up with urine now. We got to get it out of the body. So I mentioned this before. Our bladder, like our anal canal, has two sphincters. Again, a sphincter, that S-P-I-N-C-H, or H-C-T-R. Sphincter is another word that's just saying there's a little band of smooth muscle that helps control flow of things. And so, filled up with urine, we have an internal sphincter that is smooth muscle, just like the GI tract, and we have an external sphincter that is skeletal, which means we have control over it. So same concept as defecating as the anal canal is that pressure is going to be pushed on that internal sphincter, and it's going to kind of open and let urine trickle a little bit in here, and then that kind of gives us the urge of the feeling of like, oh, I've got to pee. And we hold it. We learn as a kid how to hold and control the external sphincter so we can go to the bathroom and we can put that in the toilet where it belongs, not on the floor or in our beds. Okay. Shade through. Does that make sense there? So the last section on page 401 is talking about that last structure if I talk about it. So everybody has a bladder, two kidneys. From the bladder's, again, just a muscular sac, that smooth muscle with two sphincters controlling its exit. Where's it going? It's going out the urethra. Urethra. Kind of like eureka, urethra. If you can't remember how to say that name, I don't know, think of eureka, because it feels good if you really need to pee. Eureka. Oh. So the reason they're showing the male and female urethra is just so you understand the difference. There is a big difference, and it does matter. It does really matter if you're trying to put a Foley catheter in, because Sorry, ladies are way tougher. Men are pretty easy. There's not a lot of options, for men. So, unless unfortunately, they got an innie. It happens. If you're big enough. Anyway, so dark humor as a nurse. Just ignore me. I've seen some stuff. I'm like a Vietnam vet, okay? Seen some stuff I can't forget. Anyway, so urethra is just the tube from the bladder out of the body. Urethra, they call that the urinary meatus, just the opening. So a word that we kind of talked about, but that urinary meatus, any meatus, that word here, this like meatus, meatus is just any opening in the body, okay? So technically the anus is like, they would call that like the anal canal or anal meatus, that sort of stuff. It's like an opening. So everybody's got a urethra. For females, it's much shorter. You can kind of see this, right? Because the urethra is here, anterior to the vaginal canal, and it's only like about 2.5, 3 inches long, where the male urethra is going to run whatever their penis length is, or whatever that. So the male urethra runs kind of a loop and goes all the way out. So men share the urethra with the same canal that they produce sperm through and that sort of stuff. And so it's longer. So why make that point? It means that females, unfortunately, are more prone to urinary tract infections. Much more prone. And it has a lot to do with anatomy, unfortunately. But if you kind of look at anatomy, for a female, you have the urethra. Very close to it is the vaginal canal, and vagina does carry some bacteria, okay? Some good bacteria like the GI tract, and for good reason. It kind of keeps flora. They talk about vaginal flora, but there's organisms that live there, and it's very easy for cross-contamination if you don't wipe correctly, which I hope to God every woman in this room knows how to do that, but front to back, people, okay? If no one taught you, I'm telling you now, front to back. I'm just trying to get my kids to do it without leaving the restroom. They just walk out naked, like wiping like an old person. I'm like, what are y'all doing? Just because the TV is on, they're just like, ah. I'm like, if you don't get in that bathroom, I'm going to drop kick you. All right, so front to back. Again, I know that very well. Got 4 girls, remember? So front to back, people. Because look what happened if I wipe from back to front. What's back here? Oh, anus, bacteria. Vagina, bacteria. So if I go the wrong way, I go this way, I'm taking and scraping bacteria towards the urethra, which having a short urethra means that this bacteria doesn't have that far to go, so it might implant in the bladder wall and cause inflammation and infection. And that's a UTI, which could progress all the way up the ureter, infect the kidneys. That term is actually pyelonephritis. So this is bad news. So there's a discussion about that, the urinary tract infection. I will say this, that fast fact on page 401 is good. For a UTI, urinary tract infection, the most common culprit is this bacterium called E. coli. E. coli, and that's mentioned in that fast fact. It's Escherichia coli, but who wants to say that every time? E. coli. Because where do we find E. coli a lot? In your bowels, in the stool. That's where we find E. coli. E. coli is in stool, mostly. It's one of the most common bacteria we have. So that's why males are less prone to urinary tract infections. Doesn't mean they can't get it. All it means is that bug, that bacterium, just has longer to travel to get to the bladder. So that's the difference in urethras in male and female, and that's why females are more prone to urinary tract infections, that combination of things. The last thing, and then we are done, I promise. I know I've gone long, but it's like, I want to finish. The kidney stones is discussed on page 401, and that life lesson. So kidney stones are also called renal calculi. What does calculi sound like? It sounds like a familiar word. Caniculi, yeah. But look at that word, calculi. Yeah, I was like, what? That helps you figure out what they're mostly made of. So kidney stones typically are made of calcium. They're made of calcium phosphate, uric acid, but I always just kind of highlight calcium it helps me remember that term, renal calculi. So commonly calcium, other stuff too, but it's the same concept as gallstones. Somewhat if my urine flow is a little bit sluggish and I have poor diet, again, that can lead to gallstones. The same thing. A lot of sodas can cause this sometimes too. Mainly the uric acid part of soda and other stuff, so it kind of depends. And some people are just prone to kidney stones. There's some people that eat really well and still get kidney stones. So just like anything, it's kind of dependent on luck of the draw. But kidney stones develop for a number of reasons. They're mostly formed of calcium, and they're just hard crystals. And again, just like the gallbladder, if I have a hard crystal that doesn't move, doesn't change its shape, and I have a soft tube system, well, what's going to happen? Eventually, one's going to get lodged somewhere. What does that do? Causes a backup of urine, backup of waste. So I can't get rid of my waste products. I can't get rid of the urine. I'm going to have a lot of pain. Kidney stones hurt really bad. I've been told, thank God I've never had one, but I've taken care of a lot of people with kidney stones. If you've ever had them, you can tell people they hurt pretty bad. And so a lot of times what can happen is all that fluid just builds up in the kidney and causes the kidney to have fluid build up and causes the kidney to swell. Inflammation is just like a cycle. Like inflammation here locally where the stone's stuck, backflow up, causes everything to get swelled, inflamed, just the whole thing's hurting. That condition is called hydronephrosis. So fluid buildup in the kidney, swelling because of a stone, that's hydro, like water, or fire hydrant, nephrosis. Which nephron, and then osis is usually like infection or can be inflammation too, or disease process. It's kind of all of those. But hydronephrosis is that condition, and it mentions it in there as well. So that's the need to know about kidney stones, mainly made of calcium. If they block everything up for a long time and my kidney swells, it could cause hydronephrosis. And you can pass kidney stones on your own. Sometimes they try to treat the inflammation. They try to treat the swelling in the kidney and see if someone will pass it on their own. Passing a kidney stone is like dragging a rock through your tube that is your ureter and then urethra, so it's not fun, right? Again, anything that's like soft tissue like this, right? If I'm poking it with something hard like a rock, that's going to feel like excruciating. If you can't pass it on your own, they'll do a procedure. You don't have to know this for your test, but they'll do a procedure called a lithotripsy, which basically they put a tube up the urethra, up the ureter, and they come up with a thing and just go like a little jackhammer and go, blah, 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 blah. They break it up, and it gets into small pieces, and then they let you pass it on your own. So obviously there's always a small risk of like bleeding and hurting the ureter or some part of the kidney, but that's kidney stones. Couple quick mentions at the very end, page 402. What's this picture? Is this those are all, okay. 402 talks about urination. So there's a couple words I just wanted to highlight if you hear urination. So we all know urination is I'm peeing, right? Like there's so many words, peeing, whatever. So some of the big words that they use medically to talk about is obviously urination. They use something called voiding. Have you heard that before? If you worked in healthcare at all, you've heard that. Huh? What? Oh, charting. Yeah, sorry, charting. Yes, charting, yeah. You're charting how much they voided that day or whatever you collected, that sort of stuff. Another term you haven't really ever heard of, but I think it's worth just mentioning, is called micturition. That's what that one's called. I think it's spelled like that. Micturition, maybe? That's the word at the top of the page. Yeah, micturition is how you say that, micturition. I swear I had never heard that before, even after taking A&P in college. I didn't hear that. I didn't hear this word until a doctor said it, I swear, one day, and I was like, did he have a stroke? What does that mean? I don't know what that means. I had to look it up. If you hear something you don't understand, look it up. I looked it up and I said, oh, Why don't I remember this word? Maybe I learned it and I forgot it, and that's probably the same thing that'll happen to you. But one day, maybe, could be your first year as a nurse. Maybe it's 10 years from now. You hear somebody say micturition, and you're like, oh yeah, Mr. Mawson said this would happen. But if you want to sound fancy, call voiding or urinating micturition, and you'll confuse everybody. Otherwise, I'm just making it known that that's a word that's used. The only other thing I want to make a point of is page 403 has a big life lesson about renal insufficiency and dialysis. I don't think there's that much you have to know for that, for you guys at this stage in A&P. I will just say that they're using that term renal insufficiency. You see that at the top of the life lesson? That term renal insufficiency can also be used as a synonym for renal failure, okay? So if my kidneys are failing, like my renal is kidneys, so if my kidneys are failing for whatever reason, I can say renal insufficiency. So basically all they're saying is that an extensive number of my nephrons, a lot of my nephrons have been destroyed, and this is like a disease process now. So they're saying you have renal insufficiency, that sort of stuff. Again, they use a lot of terms. Sometimes they use renal failure as well. So renal insufficiency, they might use renal failure, one of those two. But sometimes renal failure can be acute. I can regrow nephrons. Remember that nephrons are not, they can be regrown, just sometimes it's going to end up being scar tissue. It depends on how bad the damage is. Nephrons have a pretty good jump back rate. And so I can get really dehydrated. Like I was out in the desert for days. I was like rock climbing. What's that movie where he cuts off his arm when he's rock climbing? 27 hours or something, wasn't it? Anyway, that kind of thing, like I'm out surviving, then I'm probably going to have some kidney damage, but if I'm young and healthy enough, I'll probably regrow. That would be acute renal failure. Yes, I'm in renal failure, but it's acute. It just happened, and it's very sudden. But if a disease takes me, if I have something that causes it over time, that'd be chronic. But you could use renal failure or renal insufficiency. And that's all I'm highlighting. If you want to read about dialysis, it's in there. I'm not going to test you over anything with hemodialysis. You could read about it. There's basically two types. Hemodialysis, if you want to know, this is a rabbit trail. It's not something you have to know for me. But hemodialysis is literally hooking someone up to a machine. They have a catheter that goes into their blood vessel that we pull the blood out, and we do the job of the kidneys for them with a machine, and then we put it back in. Not all their blood, obviously, because they die, but most of it. And that's why people feel crappy. Dialysis sucks, and people hate it because it does not make you feel good to do that. The other one is called peritoneal dialysis, and this is a weird one, but there's actually a way to the peritoneum, that membrane we talked about with the GI system. You can actually hook up, and it'll act like a filter to help filter our blood a little bit. So they can actually use the peritoneum and a series of some tubes and filter. They put a dialysate in there. They put a dialyzer in there that helps filter blood, and they just run it through, and it actually works pretty well. The only problem with that one is you got to do that a few times a day, like 3 or 4 times a day. They have automated machines, so people can do it only at night too. There's some unique stuff like that, but I'm no expert on peritoneal dialysis. I only dealt with it a few times in my career. Most time people do that at home. You don't see them in the hospital, so that's just nice info, but you don't have to know that. And that's everything with Chapter 19. That's it.